Hi, this is Zach Englander. I'm a resident in the Department of Neurosurgery at NYP Columbia, and my talk today is titled Focus Ultrasound Mediated Blood-Brain Barrier Opening Following Radiation is Safe in a Murine-Pontine Glioma Model. I have no disclosures. DIPG makes up 10% of all pediatric central nervous system tumors and is a devastating cancer. It is highly aggressive and particularly infiltrative. This, along with the highly eloquent nature of the brainstem, makes surgical resection impossible. The current standard of care is radiation followed by systemic therapy. However, median survival remains poor at around 9 months. While we have begun to learn a lot about the molecular characteristics of these tumors within the last decade, the blood-brain barrier is thought to limit the penetrance of systemic therapies. Focus ultrasound in combination with microbubbles has been developed over the last several years to facilitate the delivery of drugs across the blood-brain barrier. The gaseous microbubbles expand and contract while being sonicated and mechanically open the tight junctions within the cerebrovasculature. Unlike systemic osmotic agents like mannitol, focus ultrasound can target regions of interest. This figure on the right depicts our setup with mice anesthetized below a single-element transducer. Given that the application of focus ultrasound in brainstem tumors has yet to be studied, we set out to test the safety and feasibility of focus ultrasound in a murine-pontine tumor model. We used a PDGFB amplified P10-P53 knockout cell line developed by our lab by viral injection in the mouse cerebrum. We implanted the cell line by injecting them into the brainstem of B6 albino mice and confirming their growth on post-injection day 13. We then randomized mice to either control, focus ultrasound, or double focus ultrasound groups. Mice in the one-time treatment group were sonicated on post-injection day 14, and those in the double focus ultrasound group were treated on post-injection day 14 and 19. A select group of mice were then sacrificed immediately after treatment for histology. The remaining mice were serially monitored for weight loss and survival. Once mice underwent ultrasound treatment, blood-brain barrier opening was confirmed on contrast-enhanced T1-weighted imaging. One mouse subsequently underwent Evans blue injection, perfusion, and brain harvesting. Gross histology revealed blood-brain barrier opening in the pattern of contrast enhancement. We also obtained serial T2 imaging, which showed no evidence of ultrasound-related hemorrhage. Repeat imaging at 72 hours demonstrated reclosure of the blood-brain barrier. Mice that underwent a second round of ultrasound had successful reopening of the BBB. To further assess safety of the treatment, we monitored cardiopulmonary vitals before, during, and after treatment. We did not see any apneic events or cardiac pauses. Motor testing was also completed with sequential weightlifting before and after treatment. There was no change in motor testing after the first treatment. We did actually see an improvement in the mice that underwent 2 rounds of treatment, but that was likely related to increased test exposure and less likely any neuromodulatory effect. Mice did not show any evidence of post-procedural weight loss. Furthermore, survival was similar in all 3 groups. Lastly, on review by 2 blinded neuropathologists, there was no difference seen between focus ultrasound and control groups. To increase the clinical relevance of these experiments, we began treating mice injected with a PDGFB amplified P53 knockout cell line harboring the H3K27 mutation, a mutation seen in the majority of patients with DIPG. The cell line was developed by the Becker lab at Northwestern via viral brainstem injection. These are slower-growing tumors that more closely resemble the infiltrative nature of DIPG both clinically and radiographically. We randomized mice to either control or focus ultrasound groups. In addition to a more relevant mouse model, we also decided to irradiate the mice prior to sonication, as radiation remains the true standard of care in these patients and the only therapy shown to increase survival. Again, motor testing was unaffected by sonication. Furthermore, survival was statistically similar in both groups. In conclusion, focus ultrasound-mediated blood-brain barrier opening is a safe method in a preclinical pontine glioma model following radiation. Future work will need to look at testing focus ultrasound-enhanced delivery of systemic therapy. I want to thank the following people and organizations for their support and guidance. Thank you.